Our first speaker today is Miles Behan, who is a cardiologist from my hospital in Edinburgh, and he's going to talk on fractional flow reserve in cardiac surgery. Okay, Miles.
Thank you very much. It's a real honour to be here and presenting as a cardiologist to a cardiac surgical conference. I actually gave a talk similar to this, I think at the meeting that was in Belfast, so before COVID. And it's interesting because I was going through the slides and I've had to change them all as the views on FFR and cardiac surgery have changed quite a bit recently. So what I'm going to talk to you about is what is fractional flow reserve, briefly talk to you about the role of fractional flow reserve in PCI, so in stents, what I do, and then is there a role for FFR in cardiac surgery, and then my own personal conclusions. If you look at this osteodiagonal lesion, it's difficult to know whether that is truly significant, i.e. it's causing an obstruction to flow to the part of heart to the part of the heart muscle that it supplies, or not. And so there's two tools that we sometimes use to further assess something other than just an angiogram. And the first one is this one on the bottom here, which is an IVUS. And an IVUS is where you pass a wire down the artery and then you pass a little intravascular ultrasound catheter down the inside of the artery, and that gives you a picture from the inside of the artery, and it'll tell you things such as the composition, whether there's a lot of calcium, it'll give you a size of the artery, and it'll tell you if there's thrombus there. But that actually doesn't give you a functional assessment of whether that narrowing is causing a problem. However, FFR does. And what an FFR is it's a measure where it's a very simple idea really, where you pass a wire down the coronary and you're measuring the pressure distal to the stenosis and then proximal, and it's a ratio of the two. There are a lot of assumptions in that calculation. However, overall, if you give maximum hyperemia, so you give the patient intravenous adenosine, it gets rid of microvascular resistance, and then that will give you a meaningful ratio. And this ratio, if the ratio is less than 0.75 to 8, it shows that the stenosis is significant. So you would then intervene on it. For us, we would stent it. And so it's a functional assessment of a coronary stenosis. And it's useful because then you can see, when you're looking at an angiogram, sometimes you do need a bit more information. Is this LAD significant? There are two lesions in it. However, when we've done a pressure wire assessment, it's 0.83, so that suggests it's not significant. You would leave it alone. However, in this artery, when you're coming down, you can see that the narrowing here, we've done an FFR, and that's 0.71. So that is significant, and therefore we would intervene on it, and we would stent it. And FFR and PCI has been very much validated in several trials, but there's three big trials. There was the DEFER trial, where this was a trial where it was really looking to see, is it safe not to intervene on FFR positive lesions, and it was found that it was safe to. So if you stented less lesions with an FFR of greater than 0.8, it was of no benefit to the patient. Then there was FAME, and this was FFR-guided PCI in multi-vessel coronary artery disease. And that just showed that actually when you see a patient and you've been told that they've got 3-vessel disease, if you actually do an FFR assessment, often it would drop to 2-vessel disease or 1-vessel disease. So you found that you could actually do less PCI. And those patients did better. And actually there was a signal that if you stented vessels that were not functionally significant, you might actually do harm. And then FAME2 was another big trial, and that just showed that FFR-guided PCI plus optimal medical therapy is better than just optimal medical therapy on its own. So FFR in PCI definitely shows improved clinical outcomes and improved cost effectiveness. And some of the benefit is from not stenting non-significant lesions. That's two negatives. Not stenting non-significant lesions. So it's led to these guidelines from the ESC, CTS, that when evidence of ischemia is not available, FFR or IFR are recommended to assess the hemodynamic significance of an intermediate grade stenosis. And likewise, then you should think about FFR-guided PCI should be considered in patients with multivessel disease undergoing PCI. So it's in our guidelines. So if you come to the cath lab, FFRs procedures are being done all the time. It's something that we strongly believe in interventional cardiology. So surely we can then think that there must be a role for it in coronary artery bypass grafting. However, I think we've got to remember that PCI and CABG are two fundamentally very different types of revascularization. But can we apply it to bypass grafting? And so there's some trials which we'll talk through. Just the first one was this Botman, and what he looked at is he did 164 patients. He FFR'd all their vessels prior to them going to surgery, and 525 grafts were performed. And then he looked at 1 year angiogram. So they all had an angiogram at 1 year, and then he looked to see how many was there a relationship between your FFR before surgery and patency of the graft at 1 year. And actually, if you bypassed functionally non-significant arteries, that resulted in a higher rate of occlusion at 1 year compared to ones that were significant. So it's 21.4 versus 9%. And as things got more significant, there was even better patency. So if in this trial suggested that if you're bypassing vessels that have a significant stenosis with an FFR, then they're more likely to be patent at 1 year. And then this was there's another trial. This was a retrospective analysis. And what they did in this hospital is they looked at 429 bypasses that were just performed on angiography alone. So that's where the surgeon just looked at the surgeon cardiologist looked at the angiogram and bypassed what he thought was appropriate, versus 198 where it was FFR guided. So the surgeon would graft things that were functionally significant only. And in the FFR group, as you might imagine, they found that there was less multivessel disease, there were less anastomosis done, and there were fewer on-pump procedures. However, this isn't randomized data, so when they looked at it, they found the FFR patients were younger and had less diabetes. However, in the angiogram-guided group, there was 4 times the graft occlusion rate. So it was suggested that there is this benefit of graft occlusion in using FFR, and at 6 years, there did appear to be a clinical benefit, and there was less death and MI in the FFR group. And at 6 years, a positive FFR, so that's one below 0.75, was associated with better patency in arterial, but not venous grafts. So it didn't seem to make a difference to patency of venous grafts, but it did seem to make a difference in patency to arterial grafts. So this has then gone on to other trials. And so in Fargo, here they took 100 patients and they randomized them either to FFR-guided or angiography-guided bypass. Everybody had an FFR, but the surgeon was then blinded to the FFR values in half the patients. So they would just graft what they would decide on the angiogram and go and graft those. It was so it was either FFR-guided revascularization or complete revascularization, and more than 75% of the grafts were venous grafts. So all non-LAD grafts effectively were venous grafts. And here they found that the primary endpoint of graft failure was similar in both groups. Clinical outcome was similar in both groups. And interestingly, after 6 months, they found that the vessels that they had left that had been FFR negative, a lot of them had progressed to become positive after 6 months, suggesting that maybe with the bypass, you do actually get this belief that you do get some disease progression. But there were issues with the trial, as it was underpowered and it took a long time to enroll, so they actually finished the trial quickly. And also there were some issues where the fact that some of the patients didn't get the revascularization that they were planned to because of intraoperative issues. So here was another trial. I'm sorry, there's only one more trial after this one to go through, but this was another trial, and here they decided to look on just arterial grafting. So this is a trial of arterial graft, FFR guided. So you have 67 patients were assessed visually with FFR. All patients received multiple arterial grafts, and then they had 6-month angiograms to look at how patent things were. And here, a preoperative FFR, if the value was less than 7.78, then that was associated with a 97% patency rate. So it did seem to suggest that if your FFR is low and you've got a functionally significant stenosis, then your arterial graft is much more likely to be patent at 6 months. And then the last trial I'm going to look at was a trial where they decided to look at, well, what would be the benefit of FFR in terms of clinical outcome, in terms of the surgical strategy, and in terms of graft patency. And so here they had 172 patients with stable angina. These guys underwent FFR guided versus angiogram only guided bypass. And here there was more arterial grafts. Arterial to venous grafts were 1-to-1. So overall, in terms of surgical strategy, the FFR group had a much more simplified surgical procedure, but at 1 year there was no difference in terms of graft patency or the composite of death, MI, or TVR or stroke. And again, there was some slight problems with the trial and the fact that it was underpowered and there was a lower event rate than they expected. But overall, on these FFR trials, you can see that the data, for various reasons, is limited. And there's differing results. In IMPAG, it correlated, the FFR correlated with graft patency. But in Fargo and Graffiti, the two other randomized trials, it didn't seem to make any difference. And this may be explained really by the difference in types of grafts that they used. Now, I'm cautious here because I'm telling some surgeons about grafts, so I don't want to show my ignorance too much, but an ideal graft is a low resistance conduit to the diseased coronary artery. Competitive flow may occur when the resistance of the graft matches that of the native artery stenosis. So competitive flow is something that we see in the cath lab when you're doing an angiogram and you're injecting down your LAD, and you'll see sort of pauses in flow because the flow is also coming down the lemma. And it's something you tend to see in arterial grafts. Vein grafts are large conduits, and they have very limited vasoreactivity. They tend to be shorter, and the resistance to blood flow is low. There's low resistance to blood flow. Vein grafts tend to go because of aggressive atherosclerosis. They are low resistance. Arterial grafts, however, are smaller, and they do have this higher vasoactive tone. They then are unlikely to get atherosclerosis. Competitive flow is not often seen with vein grafts as they have this low resistance. However, it is seen with arterial grafts as there's a pressure drop along the conduit. Competitive flow is definitely associated with decreased graft patency. And there's a linear inverse relationship between your pre-op FFR and your lemma graft flow. So if your FFR is greater than 0.75, you tend to get competitive flow and you have lower rates of patency in your lemma. And IMPAG only used arterial grafts, whereas Graffiti and Fargo used both. And that may explain why it was positive in one and not positive in the other two. But in terms of clinical outcomes, if we think about what the trial showed, they showed that FFR-guided surgery does give you a less complex surgical strategy. You bypass less. But it didn't translate into any improved clinical outcomes. There was lower anastomosis, more off-pump surgery, and more minimally invasive surgery in the FFR-guided group. However, there's no difference in terms of hospitalization, stroke, or operative mortality. And less anastomoses, as seen in the Fargo trial, didn't seem to make any difference in terms of clinical outcomes. And so I think bypass and CABG are very different types of revascularization. If you're placing a vein graft on a moderately stenosed artery, it doesn't seem to affect the outcome by placing an arterial graft. Sorry, if you're placing a vein graft on a moderately stenosed artery, it doesn't seem to affect the outcome. But if you're placing an arterial graft on a moderately stenosed artery, then you have lower patency rates. But if a graft fails on a vessel with a non-significant stenosis, then it's probably not going to result in a clinical outcome anyway, because the artery isn't significantly stenosed. Whereas if you come back to PCI, if we stent a non-significant artery, we may do harm because you're putting the patient at risk of stent thrombosis and things. So in PCI, it appears less is more, favouring an FFR approach, where it's possible that the benefit of bypass comes from this total revascularization. So actually, FFR may actually remove some of the benefit of bypass grafting. So I think what I have concluded from my conclusion now for FFR is that FFR-guided CABG does make the procedure more simple and probably results in less grafts. There's no randomized evidence, however, that FFR-guided CABG improves clinical outcomes. There was just that one observational study. I think it is important where FFR guidance may help in determining where arterial grafts should be used. I mean, if you're going to do a bypass operation, you want to know that the LAD is significantly stenosed, and you want your lima to work, so that's where an FFR will be very helpful. In multivessel disease, the benefit of FFR and PCI is in reducing the number of revascularizations needed. However, so in PCI, it's reducing the number of revascularizations gives you the benefit, and I don't think this can be extrapolated to cardiac surgery, where the aim of treatment is total revascularization. So in my opinion, until further trials and larger trials of FFR-guided surgery are done, I think the goal of surgery in multivessel disease should remain total revascularization guided by angiography alone. Thank you.
That was a terrific presentation, Dr. Behan, and I have to congratulate you on being one of the cardiologists, interventional cardiologists, who understands that the mechanism of action of these two alternate forms of revascularization are very different. Mm-hmm. PCI treats a proximal flow limiting lesion and does it very well. Coronary bypass bypasses the proximal half or 2/3 of a vessel, protecting against present flow limiting lesions and future lesions, and against rupture of non-flow limiting lesions that may occur in the future. So a primary benefit of coronary bypass is protection against future MI, which cannot be expected from PCI.
Agreed.
On the other hand, CABG will not provide benefit if the graft closes.
Agreed.
We can all agree on that. So the role of FFR is very interesting and very important. And I would argue it's especially important now that we are doing CTFFR.
Yeah.
Can you tell us, how does CTFFR differ from invasive FFR? Is it more physiologic? Does CTFFR lead to a higher syntax score than invasive FFR?
So what we're talking about is, so FFR, there's three types of FFR now. There's two where you put a wire down the artery. The first one, FFR, which is the one that is all validated and all the results come from, and that's where you give adenosine intracoronary at the same time. There's then something called IFR, where you just put a wire down, but you don't have to give adenosine, and through some very clever calculations, they've worked out that you don't. And then the CT-guided FFR, and that's the heart flow. And we were involved with trials with that in Edinburgh with Neil Uren. That is just where a CT is done, so there's nothing put down an artery. I think, although it is being accepted, it is not as specific or as sensitive as FFR. So I'd have to say that we haven't adopted it in Edinburgh at the moment, this take on CTFFR. But it will come, I'm sure, as it becomes more accurate.
Patrick Sorois, the father of the Syntax trial, has a new trial underway called the Fast Track trial, in which we are enrolling patients referred with multivessel disease to have coronary bypass surgery. And part of the team that will not participate in the planning or conduct of the operation agrees that yes, this person should have a coronary bypass operation, but the operative team sees only the CTA CTFFR.
Right.
Plans and conducts the surgery based on that alone, without seeing invasive angiography.
Wow.
We've now enrolled a little over 100 of a planned 114 patients in what is truly an observational sort of test of paradigm trial. I have the distinction or foolishness of being the only surgeon in North America enrolling patients in that trial. It's a fundamentally a European trial where lawyers are friendlier-ish.
Okay, are there any questions from the audience? Okay, yes, Jack.
Thanks very much. Great talk. Should every coronary angiogram that's been done where you find C lesions involve FFR?
So I think if you are confident that the lesion is stenotic, so on an angiogram you are confident that it looks tight or it's, then I think it's reasonable that they don't have an FFR. However, particularly for things such as that the LAD on the lemur, I think if there's any doubt, it should be performed. And normally in our centre, the cardiologist will say, look, this guy has got 3-vessel disease or 2-vessel disease or whatever it is. The onus should be on us to provide the correct data so that you know what is significant and what isn't. So not every angiogram needs an FFR, but when it is needed, it should be done.
Now, in the previous session at the tail end, there was conversation about, gee whiz, would you use the same IMA to graft the diagonal and the LAD, or the same IMA inflow for the LAD and the circumflex, depending upon varying degrees of stenosis? And those were described in the conversation and exchange of ideas based on invasive angiography. But CTA, CTFFR will give you an FFR for every vessel. Now, I am obliged to actually believe the numbers.
Yep.
You're telling me that perhaps is naive.
Well, our experience of it, which was a few years ago, was less impressive than that. However, it's
and the reason I ask about whether these, to relate to the question earlier that you were left answering, with the benefit of CTFFR for every single branch of every vessel, produced with this algorithm and produced in a color-coded, numerically graded 3D animation, I can decide whether I want one inflow to that LED and the circ, or whether I can tolerate or need two. I can rearrange my arterial grafts thinking it through, but I'm relying on believing the numbers, which, is concerning.
But going back to your question, so it doesn't. I don't think it needs one for every angiogram, but you need to be confident that you are bypassing stenotic vessels.
Can I just add?
The other way around. If I had an invasive angiogram that doesn't demonstrate on the old-fashioned thinking a serious lesion of the proximal LAD, but the FFR tells me it's really serious.
Yes, I would believe the FFR. Believe the FFR.
And most cardiologists do. They believe the FFR. When the eye disagrees with the FFR, they're believing the FFR, which, they have a lot more experiences than we do. We ought to pay attention to that belief.
The FFR never lies.
And I think on the right coronary artery, I think the FFR is more important, because what appears as a 70% or a 80% or a 90% lesion may give different FFR values. Even if on the right side, even if a lesion appears 80 or 90 to the eye, sometimes the FFR comes as non-significant.
And those arteries are safe to leave. Those lesions are safe to leave.
Well, from a PCI perspective, they're safe to leave. Yeah. And whether they're safe to leave from a coronary bypass perspective, I think is less well understood. And I think it's important to understand that the higher the FFR, the less significant by FFR is a lesion, the worse the patency of your graft. But it's not a cliff. There's not magic at 0.8, where at 0.76 every graft is patent and at 0.81 they all close. That is not true. It is a continuous variable, not a dichotomous variable. And so, as you pointed out, with decreasing FFRs, failure rates went from 20 to about 8%. 20% graft failure means 80% patency. And if the 20% failure is clinically silent, you have 80% open with future benefit. That's a surgeon's way of thinking, not necessarily a cardiologist's way of thinking. And we have to share our ideas.
But I'm coming round to the idea that maybe, you know, for bypass, you are aiming for this protective effect rather than just, you know, so that,
Yeah.
you know.
And in the trial, one of your comments is the trial is weakened because of you know, surgeons not complying with leaving borderline FFR lesions. Guilty as charged.
Mm-hmm.
I mean, you know, I graft if it's remotely positive on the FFR, I'm grafting it. I am not leaving it behind. I live in a world. I swim among sharks. You know, I'm not leaving an unbypassed vessel there.
Okay, Piroz, use the mic.
Coming to what John said about it's not a cliff. So what would you consider any value of an FFR where you would say no, there's no point in grafting those?
Sorry, can you
If it's 0.9 or 0.9 or 1, of course you won't, but 0.9.
It's difficult, but you know, if you asked me and I knew that the FFR was greater than 0.8, I would probably say don't graft it.
Right.
But what's happened is the FFR is maybe making the situation more confusing by knowing it in that circumstance. You know.
Dr. Behan, can you educate us? How did 0.8 become the magic number in the cardiology literature, which we're now asking ourselves, should it be the magic number in the cardiac surgical literature? And the answer might be no. Maybe there's a different number for a vein graft or for an artery graft. But how did it get to be the right number for a stent?
It's been pulled out of various trials and worked. Initially, it was actually 0.66, and then it moved up to 0.75, and most of the data is from actually 0.75. But they've allowed it to go to 0.8 to give it a fudge factor, so that it's this grey zone is between 0.75 and 0.8. But above 0.8, it really shouldn't be flow limiting.
And that's based on physics.
Physics.
Okay, one last question. Yes. Can you wait for the mic, please? Yeah.
Abdurrahman from Dublin. Just as regard FFR, any factor affect the result give false positive or false negative?
Very, very good question. So there are some things. So first of all, things such as if the vessel gives a lot of collaterals, it may actually not look that tight, but the FFR may be positive because you know, the vessel is supplying a large territory. But certainly in things like heart failure or aortic stenosis, you can have falsely reassuring results. It can give you a false negative. It can raise the FFR. So you've got to be careful of that. And that's why it doesn't work in patients with aortic stenosis, or we're cautious of using it in patients with aortic stenosis.
Does that apply to just LV hypertrophy from hypertension as well?
Yes, yes.
Because
Extreme
the
LVH.
mechanism is LVH.
That's right. It's the microvascular.
Thank you.
Thank you.
Yes.
Joy Edlin, Senior Cardiac Surgery Registrar at Heffield. You're going to find a lot of patients excluded from your study because the CTFFR relies on a lot of assumptions to be able to make those calculations. So you'll be excluding your patients with LVH, severe AS, but also with CTOs and retrograde flow because you can't calculate the FFR for them in CTFFR.
That's certainly true, but we can image the CTO with the coronary CTA, and we'll still graft it. That is not. None of those things are actually exclusion criteria for this trial. Interestingly, previous stenting is, and that's really, it's a very short list. Metal that includes CT visibility of a lesion significance, that excludes the patient. So prior stenting is by far the biggest exclusion. But we do not have an exclusion criteria around LVH, which is ubiquitous in hypertensive diabetic Americans, and actually interesting, nor aortic stenosis. Although if the patient is clinically significant AS, they're having a combined CABG valve, and therefore they're not in this trial. This is primary isolated CABG, no previous stents. But I asked about these are the very first CTFFRs I've ever seen. After operating on 8,000 patients, probably seen 25,000 invasive angiograms. I'm now operating based on something that's brand new to me. And the first 2 patients that showed up, they were sent through my clinic. The first one had a Syntax score of 66, according to this modality, and the second had a Syntax score of 75. Now, I operate on a lot of sick people, but that seems high to me. So I'm asking, hey, are these numbers real? What the heck's going on here?
I don't know. I think that, but it probably is the way forward, because, you know, if it means you're one less invasive procedure, but it's just, I think it needs to be validated.
Okay. Well, thank you very much, Miles. That was and Miles will be leaving us because he's got a flight to catch. And Miles, if you miss the flight, we have a pub quiz tonight. Okay. Yes. Okay. So who's the next one? Okay. Yeah. Okay. Can I now invite Shahzad Raza, who's a consultant surgeon at Harefield Hospital. He'll be speaking on arterial revascularization.
Thank you, Vikman. I'd like to thank the organizing committee for the privilege to talk about a topic which I think remains the most talked about topic in surgical revascularization for the last 2 decades. So I'm going to be talking about arterial revascularization, and I have no disclosures to make. So what is the CABG landscape? Coronary artery bypass grafting remains the gold standard for treatment of multivessel disease in patients with higher disease burden, with lean complexity, and in the presence of diabetes. And I have a graph here which I've taken from one of the publications from Dr. Puska's group, which essentially shows that it is one of the most commonly performed procedures. And according to the data from Organization for Economic Cooperation and Development, CABG is on average performed at a rate of 44 per 100,000 individuals. So in essence, I think there's about 300,000 CABG procedures performed worldwide. However, it is also a procedure which is under threat. CABG is not the same as it was 50 years ago. It has changed, and the threats are both external and internal. The external threat is from our cardiology colleagues. They come up with newer technologies, whereas internally, we've not been able to reduce the invasiveness of the procedure significantly. And I think the Achilles heel, or the biggest threat, is the patency of the vein graft. Those of us who use veins, we all know that saphenous vein graft failure ranges from 6 to 26% in the first year, and it is estimated to be around 50% at 10 years after CABG. So any operation where you've used vein grafts, you're more likely to see an intervention 10 years down the line. Traditionally, CABG is performed with vein grafts and a lemur to the LAD, and the lemur to the LAD is the gold standard. And here is a publication which gives it that status or standard. This is a publication from the Cleveland Clinic group, who showed that for 5,000 patients where they had 2,000 patients where they used lemur to the LAD, they compared them with patients who had all vein grafts. And essentially what they proved, or what they showed, was that patients who had only vein grafts had a 1.6 times greater risk of death throughout the 10 years as compared with those who had internal mammary artery graft. So essentially what they are saying is that if you do a lemur to LAD, your patients are more likely to live longer. And this essentially is the rationale for arterial revascularization. You use more grafts which are arterial, you're going to have long-term patency, you're going to have improved survival, and there is this view that arterial grafts are resistant to atheromatous changes, and they also cause synthesis of nitric oxide, which prevents atheromatous changes in the vessel beyond the site where they've been grafted. And you can see the patency of arterial grafts. Most of them have got patencies in excess of 90%, and this is way better than that of vein grafts. So obviously, if one IM is good, to have to be better. And this is something, here is a seminal paper from 1999 published in the Journal of Thoracic and Cardiovascular Surgery by the same group, which showed that if you use 2 ITAs or 2 internal mammary artery grafts, you decrease the risk of death, reoperation, and angioplasty. There's a difference in survival. There's a difference in need for reintervention. In 2001, David Taggart published a systematic review, and essentially he looked at all the evidence published at that particular point in time, comparing single internal mammary artery with 2 arterial mammary artery grafts. And what he showed was that there was a significant reduction in mortality, which is attributable to the use of bilateral internal mammary arteries. And this particular systematic review then spurred him to plan the arterial revascularization trial, and I'm going to allude to that in a minute. I mean, we are all working in an era of evidence-based medicine, so every time you talk to a surgeon, he asks you, what is the evidence? And here is the evidence. I mean, if you use BIMA or radial artery graft as your search term in Medline, you would find around 5,000 publications over the last 30 years. There's over 100 meta-analysis comparing all aspects of arterial grafting. There are 4 randomized controlled trials for BIMA comparing BIMA and CIMA. There are 7 randomized controlled trials comparing conventional saphenous vein with radial artery. And there's lots of other trials comparing REMA and radial. So essentially, if you want to know what the evidence is, there's lots of evidence out there to prove that arterial revascularization is something that should be offered to our patients because it's beneficial. We did a network meta-analysis because obviously if 2 arterial grafts are better than 1, then the most logical question is which of these arterial grafts should we be using? Should we be using a REMA or a radial? And interestingly, we did a network meta-analysis in 2015, looking at all the evidence out there, comparing the various arterial grafts. And what we showed in that network meta-analysis was that there is a slight advantage if you use a REMA, although if you look at all the trials that are out there, there isn't a huge difference in terms of patency or clinical outcomes. And again, it all boils down to who's using it and how they're using it. If you look at the patency, this is a slide from the RAPCO trial. And essentially what it shows is that there's not a huge difference between the patency rates of REMA and radial when used appropriately. On the left-hand side, I've got a table which is from a publication by Maria Godino, and essentially it gives you the criteria or the selection criteria for using radial versus the REMA. Now, here is a trial which attracted a lot of hype, and you'd be surprised I've used art or fart. So essentially, what I mean here is that it's a failed arterial revascularization trial. Sadly, no trial of arterial grafting has damaged arterial grafting more than the ART trial. And the reason I say that is, in the States, there's already, deep sternal wound infection is a never event. And what this trial basically shows is that if you use bilateral internal mammary arteries, you increase the risk of sternal wound infection. But more importantly, it failed to show any difference in survival at 10 years. And there's lots of reasons that have been given by David Taggart and his co-authors. I think the most important reason is that people who contributed to this trial, a lot of them were unable to offer the operation that patients were randomized to have. And that, again, suggests that if you're not comfortable at doing an operation and you're contributing to a trial, you're likely to cause more harm than benefit, both to the patient as well as to the trial. Here we are. This is the current status of multiple arterial grafting. In 2016, in the United Kingdom, only 10% of the patients were getting 2 arterial grafts. And the situation is no different across the other side of the Atlantic. Godino and his colleagues have done a big analysis of the STS database, and essentially they looked at patients who were 50 years or younger, and these are super fit patients. Generally, if you're younger, you're expected to be fit and young, and you're more likely to receive multiple arterial grafts. But interestingly, in this particular group of patients, only 14% of the patients receive multiple arterial grafting. So clearly, if it is the best operation to offer your patients, something is not right, and they're not getting the operation that they should be offered. What was also interesting is that even across the Atlantic, beta grafting is the more preferred strategy, and 8% of the patients would receive 3 or more arterial grafts from the surgeons who know how to do it, basically. So obviously, what are the barriers to universal adoption? I mean, if 2 arterial grafts are better than 1, and they should be offered to most of our patients, what is the reason that we're not doing the operation that we should be doing? And there's plenty of reasons for it. There are patient-related factors. Sternal wound infection, it basically stops us from using bilateral internal mammary arteries. People talk about skeletonization as one way of reducing sternal wound infection, but if you don't want to use bilateral internal mammary arteries, it doesn't matter whether you use skeletonized or pedicled internal mammary arteries. There's a perceived increased risk of bleeding. There are conduit-related factors such as hyperperfusion and graft spasm. There's the issue of competitive flow. We've already talked a lot about it. Radial arterial grafts, are generally not available at least for 3 months if they've been used for catheterization by our cardiology colleagues. I think surgeon-related factor, and I think these are the most important factors in my opinion. If you lack expertise, if you've never been trained to use an arterial graft, you're not going to use an arterial graft. And also, sadly, a lot of us are dinosaurs. We are reluctant to change. We're not going to change our practice no matter how much evidence is out there. And then there are the organization-related factors. There's no incentive for me to change my practice. Why should I? I'm not going to be paid extra to do an operation which is more technically demanding. There is, again, a lack of consensus. And of course, increased theater time is an important reason for not doing the operation that we should all be trying to do, or at least, we should attempt to do. On the left side, there is a graph which I've taken from a publication which is in press. It's a survey of the surgeons in Maryland State in America. And essentially what it shows is that the most common reasons cited by surgeons in that state for not doing multiple arterial grafting is the risk of post-operative complications. Now this has all changed, 20 years ago, if you surveyed the surgeons, and I'm going to show you that in a second, there was no proof of benefit. So we had an excuse. The excuse was there is no evidence. Now we say, because you increase the risk of post-operative complications, you don't want to do multiple arterial grafting. And as my friend Mario says, cardiac surgeons are like fishermen. When they don't want to do something, they will always have something interesting to tell you. There's always a nice story for not doing the right thing, and that's how we are, sadly, But again, you look at surveys, worryingly, 35% of our residents don't know how to skeletonize internal mammary artery. 70% of them have not even harvested a radial artery. So obviously, the issue is something more than evidence, something more than the risk of complications. And here it is, do all roads lead to Roma? So art failed. Now, Mario Godino is, hyper about this trial. He seems to think that everything's going to change, once we have the results of the Roma trial. And Roma trial basically is, again, looking at radial as a second graft. Whether that's going to be the case, who knows? But I wouldn't get my hopes very high, and I'll tell you why. Here it is. This is it. We have to train. If we don't train the future surgeons, we'll never be able to increase the uptake of arterial grafts. And this has all to be done in a systematic manner. We've got to teach the future surgeons how to harvest all the arterial conduits. That's the first step. Half of them have never harvested a radial. If you've not taught them how to, harvest a radial, they'll never use it. You've got to then show them how to use a radial artery, what are the appropriate patients for a radial artery, how to use in situ bilateral internal thoracic arteries, how to use composite, internal thoracic and radial internal thoracic artery grafts. We've got to teach them how to do an anaortic op-cap. And finally, we have to move to minimally invasive multiple arterial grafting. And basically, this pyramid shows you that surgical revascularization is a very complex field. It should be a subspecialty. Unless we all agree and accept it as a subspecialty, we'll not be able to increase the uptake of arterial grafts. And of course, sharing is caring. I'm a big believer that if you do something good, you must share it with everyone. You must share your experiences. You must, show all your good work and try and encourage others to do the same. So, we've over the years done a lot of work with bilateral internal thoracic arteries, and we've published all aspects of bilateral internal thoracic artery grafting. It is, for us, pretty much a standard operation in our institution. More than 60% of the surgeons in Harefield would use bilateral internal thoracic artery as a procedure of first choice and offer it to all appropriate patients. Thank you very much.
From whom is that quoted? The greatest threat to surgical revascularization is the belief that someone else will save it.
Well, this is my creation, Doctor.
You might be right.
Yeah.
Okay, do we have any questions from the audience, Shakil? Yes.
Thank you. That was a really good talk. I agree with most of the things you said. However, I think there are still things that is beyond our control. If you look at the real world data, even the latest study that came out of following from the COMPASS study, that showed 26% occlusion rate of REMA and, good patency rate of radial vein. I mean, vein patency was around 80%. The radial rate was around 90%. Lima rate obviously was very high. So I think there are so many factors, not only the handling and technical aspects, but also which graft you're putting where. I mean, following from our last discussion, if it's a moderate stenosis, I'm not entirely sure whether putting a radial or a REMA in that artery is good or not. So I don't think that we can come up with a blanket statement that more arterial graft would be better. It obviously has to be tailored to the patient. The technical aspect has to be perfect, but the selection of the patient and selection of the target vessel matched with the target conduit is very important as well. And off-pump, on-pump debate that has been going on for the last 30 years. I do not think any trial has shown any advantage of off-pump or on-pump. On the contrary, there are trials showing that if it's not done in the right hand, off-pump can give worse results. Having said that, centers who are doing off-pump regularly, they're achieving fantastic results. So I think that's one of the problems. And the newer generation surgeons, when I look at in our institute, the surgeons who have been appointed within the last few years, they're using more and more arterial grafts compared to the generation before. Thank you.
I mean, I think you're absolutely right. You've hit the nail on the head. The key or the crux of the matter is that the newer generation of surgeons are now being trained to use these arterial grafts, But I can tell you that if we don't do more, in 30 years, there won't be any debate about arterial grafting or off-pump or on-pump. They will be gone. The cardiologist will fix everything in the cath lab, and we would just be reading about cabbage, as a mystical operation. I think what this COMPASS trial also shows is the fact that if you're not trained to use a conduit, you're going to have poor outcomes. They used 26 REMAs, and 82% of them were blocked. it basically suggests that, these guys who were trying to use the REMA were basically novices. They had never used a REMA. So your point is well made, you have, it's not just about doing the operation, it's also about knowing when to do the right operation. If you do the right operation with the right sort of conduits and you've been properly trained to do it, the outcomes are going to be good. Centers which do lots of off-pump, there we don't have the debate about is it a good operation or not a good operation, The surgeons who do off-pump on a daily basis, they just do it. They get on with it and do it. And their colleagues who do off-pump, on-pump cases, they never engage in a debate. In fact, they would always come and knock on your door and ask you to do an operation because they feel that it'll be better done by an off-pump surgeon. So I think, we've got to move away from this debate of which is better. We've got to do something that is going to keep the specialty alive. Otherwise, the future is hybrid. The future is Lima to LAD with 2 stents, and that is not going to, go away if we don't do the right procedure for our patients and train our future generation of cardiac surgeons.
Okay. Thank you, Shahzad. I think in the interest of time, we have to move on. So can I now ask John Puskas to give the next talk? John has come all the way from America just to give this talk to us. He is a professor of cardiovascular surgery, and he's a cardiac surgeon at Mount Sinai Hospital. He's also the co-founder of the International Society for Coronary Artery Surgery, and he's the co-chair of the International Coronary Congress, which is held in New York every other year. And every other year, it moves to different parts of the world. And I think in 2024, the International Coronary Congress will come to UK, so all of us will have a chance to attend it at home. So, John, you're going to talk on TTFM and flow measurements.
Yeah, this is a really important part of coronary bypass, getting it right. And we do have some tools to tell us whether bypass grafts, first to help us create the bypass grafts more easily and with more confidence, and then to determine that they are in fact patent before we leave the room. These are my disclosures, and perhaps most important among them is that I am a consultant to Medistim that manufactures most of the tools that we're going to talk about. I'm going to briefly talk about the REQUEST trial. This is really a registry trial to determine the number and type of changes one might make to surgical procedures during coronary bypass if we routinely use transit time flow meter and epicardiac ultrasound during coronary bypass surgery. So this was a prospective study of 1,000 patients at 7 sites in Europe and North America, and sponsored by Medistim. These are the devices used. A transit time flow meter device helps us measure the flow directly in a bypass graft. It can be a vein or an artery. And then this epicardiac ultrasound or imaging probe helps us make pictures of coronary arteries, coronary anatomy, proximal distal anastomoses, or even the conduits themselves. And all of that is displayed on a particular screen in the operating room. So the results were, I think, quite eye-opening. About a quarter of patients had at least one change in surgical strategy determined by information provided to the surgical team by the use of these 2 tools. And it spanned both choosing where on the coronary target to put an anastomosis, where on the aorta to put a proximal, or how to manipulate the aorta, and what to do in terms of a mediocre graft, whether to revise it or not. So one of the key things is to plan the aortic manipulation. One of our earlier speakers said that the Achilles heel of coronary bypass surgery is PCI. I actually think the Achilles heel of coronary bypass surgery are 2 things. Stroke, because the cardiologists say that PCI doesn't cause stroke, and they're mostly right, and vein graft failure, because the biggest advantage of coronary bypass over PCI is durable benefit, and veins aren't very durable. That said, if you're going to do proximal anastomosis, let's do it without causing a stroke. And so choosing the spot on the aorta to construct your proximal anastomosis, whether it's on bump with a clamp, preferably a single clamp, or off pump with a heartstring device, a clampless facilitating anastomotic device, you want it to be in the best place. In about 10% of cases, the choice for aortic manipulation or site of proximal anastomosis was altered by the routine use of these tools. And similarly, about 20% of patients had refinement of the choice of distal anastomotic site on the coronary artery by use of the epicardiac ultrasound. Now, the kind of scariest thing is when you do a bypass graft and you don't like the flow in it, and you ask yourself, gee whiz, should I redo this? What are my criteria to do so? How do I know I'm doing the right thing? Well, the revision rate was about 3%. 80 out of almost 3,000 distal anastomoses were revised, and they had to do with low flow, typically documented by TTFM, and then investigated by one or another maneuver, commonly involving use of the imaging probe to sort of seal the deal that we got to redo this graft. And now, in the European guidelines, routine intraoperative flow graft flow measurement should be considered, gets a 2A recommendation. I would argue it should be higher than that, but 2A is pretty good. So what are these things? Transit time flow meter and epicardiac ultrasonography. How do I use them? I use TTFM for every graft in every case, without exceptions. It's just a routine thing. I can't imagine why we would consider coronary bypass to be the only vascular surgical procedure that doesn't have a completion assessment of the graft function. I mean, your vascular colleagues who are bypassing the foot would never leave the room without a completion angiogram. But we routinely leave the operating rooms after grafting the coronary arteries without documenting patency of what we've done. We say, I'm really good. I saw every stitch. This is perfect. Why is it perfect? Because I say it's perfect. Does every patient live 20 years? No. Can we do better? Probably. So I use TTFM for every graft in every case. And now, which of the various metrics that it provides you is most reliable? Well, I tend to go with the flow, to borrow David Taggart's phrase. And that means I trust the graft is okay if the flow and the pulsatility indices are good. And I reserve the use of the extracardiac or epicardiac ultrasound for further investigation of grafts with questionable TTFM results, especially if I feel that the graft is a good graft. And then maybe the TTFM maybe isn't as great as I wanted it to be, but it's not bad, and I might leave that alone. However, I do not talk myself into believing that bad TTFM results are okay. You shouldn't wish them away. And then we get out the epicardiac ultrasound and investigate those grafts that have questionable TTFM results, starting with the proximal anastomosis, which may be on the ITA in most of our cases, or the mid-conduit. Look for dissection or atherosclerosis. Calcification of radial artery conduits can be difficult to detect, and right there in the middle of your radial artery that has a high pulsatility index and a low flow may be a calcified lesion. Go find it, resect it, reanastomose it. ITA grafts harvested skeletonized fashion by trainees aren't always perfect. That little purple area may be hiding a small dissection flap. That can be transected, resected, and reanastomosed. Locating intramyocardial coronary targets, or of course the distal anastomosis may be the culprit as well. We surgeons really focus on that, and we somehow have got in a mindset that if I'd done a perfect anastomosis, the rest of the operation is insignificant. Well, it doesn't actually do itself. You've got to do the rest as well, and that means conduit harvesting and preparation, inflow and outflow. Now, the epicardiac ultrasound is also very handy in identifying intramyocardial coronary targets. So I'm going to tell you, show you a few cases. The first one is where I think this TTFM may well have sort of saved my patient. This was an OPCAB with 2 arterial grafts, a Lima LAD, radial to the OM, and these were all separate grafts. This is an older case with proximal anastomosis with heartstring device. So the Medistim transit flow for the vein to the PDA was great, 38 cc's per minute. Pulsatile index is less than 5 on the right. Radial artery to the OM, 26. PI is 2.8. We're going to take that. The diagonal vein graft is colossal, 101 cc's with a PI of 1.3. Sort of raises eyebrows. It was a big diagonal, but gee whiz, that seems like a lot. And then here's the bad news. The Lima to the LED has a flow of 5, and the pulsatility index is 8. Now, you don't have to be a rocket scientist to understand that the flow should exceed the pulsatility index. And when that ratio is inverted, you got a problem. You can't talk yourself into believing that one's okay. All right, there's something wrong. So what are we going to do? Leave it alone? Redo it? Or is this competitive flow from that diagonal that had the unexpectedly large flow? I was betting number 3. And this is the reason I'm showing this slide, this case, because we then went on to occlude the vein graft to the diagonal and then tested the flow in the Lima. So now we don't have any competitive flow, and that did not change the performance of the Lima graft, to my surprise and disappointment. So we redid the Lima, and then we repeated the TTFM, and the flow is now 23 with a PI of 2.9. Now, I had seen every single stitch placed by my junior in that anastomosis, and I actually gave him a little round of applause. I thought it was a perfect anastomosis, and I was wrong. The Lima flow was unacceptable, and it wasn't due to competitive flow. When we took it down, there was no apparent problem, just a slight asymmetry at the toe, and I'm guessing that asymmetry mattered. I extended the arterotomy a little further down distally, trimmed the Lima, and re-anastomosed it myself, and the flow was very acceptable as a result. But that important problem with the Lima, it was not associated with an intraoperative EKG change, and I would not have known about it had I not done the TTFM. That patient would have left theater with the inadequate revascularization of the LED. And a couple more cases. What do you do if the Lima has poor flow? So the resident's taking down the skeletonized ITA and the flow is mediocre. There's a little focal purple region in its mid portion. So ultrasound confirms a dissection flap, and the flap is visible in this cross-sectional view. What do we do now? We excised that, reconstructed it end-to-end, and used it for an ITA graft, and it was just fine. There's the flow in a different case. So here's a second, so that was fine. Here's the next case. It's apparently good mammary, but the flow is poor. So the first was a bad mammary we hadn't even used. This is a good mammary. Had good flow before we put it to the LED, but now it's on the LED, and the flow is not so great. It's less than 10. Pulsatility index is greater than 3. That's not awful, but it's not great, and the anastomosis looks a little flat. So we took that down, redid it, and now the flow is 24. The PI is 2.4. And you can see a nice imaging probe assessment of the anastomosis. So this really, I think, emphasizes that both these modalities are essential to get optimal quality control in coronary bypass, and especially in a teaching program. Now, finding intramyocardial LEDs, especially for the off-pump surgeon, can be a pain in the neck. I'm going to show you 2 cases where the epicardiac ultrasound really made a difference. So here's a middle-aged guy having a triple bypass, opening the pericardium, can't see the LED anywhere over its entire length. We bring the ultrasound into the field and we use it to identify the LED, in particular to identify the ideal site to cut down. Whether you're on pump or off pump, we want to avoid extensive multiple incisions in the anterior wall, but especially off pump. And we were able to do so and get a good result. Now here's this image. This is the kind of picture you get. So there's the target site. We identified it as a slight hump. That was the spot we cut down on. We could see that the depth of the LED below the epicardial surface was about 3 millimeters. We can cut that deep with some confidence. And there's still about 5 millimeters of muscle between the LED and the ventricle. So that looks like a reasonable place to go digging. And indeed, that's worked out just fine with the benefit of this kind of imaging. Now, here's another case. a frail 78-year-old British guy on a cruise ship, comes to New York with his girlfriend, I might add. He has an MI pulling into port. No comment. They bring him to the emergency room. She comes with him, but then she gets back on the ship and goes back to England, interestingly, leaves him with me. I don't know. Maybe she had a better offer. But he was calf to the right radial and showed a lot of disease. EF was low, kind of got him over his MI, let the Berlinta wear off, et cetera, His pre-op chest CT shows really significant calcification of the ascending aorta, and we plan an all-arterial, no aortic touch, two-vessel bypass. The radial can't be used. Right was calf, the left fails. So we decide on skeletonized bilateral mammary. Okay, we open the pericardium, and we can only see the LAD at the distal, truly at the apex, where it's relatively small, but it's far away and the LITA will not reach. What are we going to do? We go looking with the probe first, and the mid-LAD was very deeply intramyocardial, basically intimate with the ventricular endocardium. There's essentially 0 to 1 millimeter distance between the ventricle and the posterior wall of the LAD. Now, more distally, you can see the LAD rising towards the epicardial surface. So we initially had a go at finding it in the middle, of course. Then we got the ultrasound probe out and found it was very deep, too deep. What to do? We disconnected the right mammary from the chest wall and sutured it to the side of the left mammary. With that, the right mammary would easily reach the apical LAD, which we used it for bypass, and the skeletonized left mammary reached the OM. Neither had any tension. This is what it looks like at the end. You can see a T graft with the Rita going to the LAD. That's actually a different patient, by the way, my confession, but same concept. And the Rita to LAD had good flow. The Lita to the circ had good flow, low pulsatile indices. And this gentleman did well, and actually he flew back because the ship had left him back to the UK. So speaking of the UK, Oxford published this book that David and I edited, and some of the speakers in this room are co-authors of various chapters. It contains a lot of really arcane and nitty-gritty detail about every aspect of surgical revascularization. Vipin commented on this International Society for Coronary Artery Surgery. I encourage you to have a look online. The mission of this society is to advance the state-of-the-art in surgical coronary revascularization and thereby to improve the care of patients with coronary artery disease worldwide. It's truly a global initiative. Our board members span all continents. It is now the parent organization of the International Coronary Congress, which has now had 8 annual meetings, most recently in Tokyo. But as Vipin said, we're every other year in New York, and we will be back in New York later this year, the first weekend of December, to spend 2.5 days talking about every detail one can think of in multiple plenary and parallel sessions about the science and art of surgical revascularization. Thank you for your attention.
Okay, thank you. Any questions from the audience? Okay, yes, at the back. Can we have the mic, please?
Hi, this is Moin from Liverpool Heart and Chest. Thanks for your excellent presentation. How appropriate would be transit time flow in pedicle memory when we have vein, we have soft tissue and everything, because there is there overestimation or underestimation or the appropriate result? Because I can see your cases, all were skeletonized memory, which is fine. If you can have an input.
Sure, you're quite right. The pedicled mammary, especially the big old sort of beefy pedicle that we used to take years ago, you can't use the transit time flow meter tool without skeletonizing or semi-skeletonizing part. And you can find the easiest place. The last thing you want to do is ruin your mammary artery while you're assessing its flow. That's not going to make you happy.
Yes, I have seen it twice.
Yeah. So this process has to be accomplished with some care. One strategy is to create the place where you're going to later test it before you do the distal anastomosis, so that you have the mammary pedicle in your left hand, presuming you're right-handed, and you can use your two hands with complete confidence in an immobile mammary artery to denude that area where you're going to later put the probe later in the operation. If I were to do a skeletonized mammary, that's how I would do TTFM on it. I would prepare my spot for my testing, make that site safely, and then go on with my operation.
What I use a pedicle mammary, and I use what I do is then use two coronary forceps to separate the veins from the artery, and then use a right angle Shaughnessy or a right angle forceps to just go under the mammary and open it up. So you get about 5 millimeters to 1 millimeter of space under the artery where you can then put the TTFM probe.
Do you clip the vein or no?
No.
No,
Okay,
when you
fine,
measure
yeah.
the flows, you should not, the probe should not take the vein. It should just be around the artery. So you have to dissect about a centimeter of the mammary.
Yeah.
So you have to skeletonize at least a centimeter of the mammary.
Another little trick is that a 3 millimeter flow probe is easier to get around a 2 millimeter mammary artery than is a 2 millimeter flow probe. And with a little jelly, you'll get adequate acoustic coupling and get measurements that are real.
Thank you.
Yes, Spiros. Can we have the mic, please, here?
Can you comment on how you address competitive flow on a TTFM? Like sometimes.
Sure. So what do we do about that? I mean, as you know, our standard operation is 2 mammary arteries, radial artery outflows, 3, 4, 5 grafts, no aortic touch, off pump. That's our basic operation. 80% of what I do is that operation. 2 inflows, 3 to 5 outflows, all arteries. So when we think about how to construct those arteries and whether to, do a proximal anastomosis on the aorta because of competitive flow, we look at the angiogram pre-op and try to stay out of trouble. Every once in a while, you end up with a sequential or baby Y radial artery coming off an ITA, and there's evidence of competitive flow. If you're testing the flow in an arterial graft, we will typically leave the silastic vessel loop in place and not tight to do the test. So it's physiologic. If the result of that test makes me think that there may be competitive flow from the native, I can simply pull up a little more on that loop. If we think the competitive flow is from a side limb graft, then a soft bulldog across that briefly can be done. But again, what you're doing there is trying to make your TTFM good enough for you to keep moving and close the patient and go on with your day. But don't talk yourself into believing that a bad TTFM is okay.
No, so, yeah.
In the example you've given, the Sevnus graft was
Yeah. Tremendous flow, but that wasn't the problem.
So what happened? How did you resolve that?
I redid the distal anastomosis on the Lima. There was a problem with the toe of the distal anastomosis that my junior resident had done. And it was subtle. Because it, from the outside, the graft looked pretty okay. Maybe a little asymmetric at the toe. From the inside, it looked a little more asymmetric. And again, when I cut it 2 millimeters further and redid the anastomosis, the flow was tripled, and the pulsatile index was cut by, a factor of 4, and we still had abundant flow in the diagonal. The simple truth is the diagonal was very tight proximally and was a big vessel.
So it was an anastomotic.
It was an anastomotic problem of the LETA to the LAD, yes.
And there was the second example you've given.
So the high flow in the diagonal was what I thought was the problem, competitive flow. And I show the case because I was fooled twice in one case. I thought the distal on the LED was okay, and then when the TTFM wasn't great, I thought it was the competitive flow from the diagonal, and I was wrong twice. And I've done this before.
And the other example you've given, the good flow lima, but when anastomosed was bad flow.
Yeah.
How did you resolve that?
So the lima, the IMA had good flow before it was used.
Yeah.
So we felt it was a good quality conduit, and now we have poor outflow.
Yeah.
So it's either competitive flow or a failure of the distal anastomosis.
Again,
and it
the
was the
same.
latter.
Yeah.
You know.
Okay, Cha.
Yeah. Hey.
Hey, great talk. Thanks very much. I asked the cardiologist earlier on, should every coronary angiogram have a TTFM, FFR done? And the answer was yes. And
But they don't
it's
do
not,
it.
they don't do it.
No. No,
So-
they probably do it about as often as we do TTFM.
Exactly. So
There's something in that, isn't there?
there's something wrong, isn't there? So there are two surgeons here, one from the US, one from the UK, who are doing TTFM routinely.
Yeah.
Why aren't we?
I think many centers do routinely. In Edinburgh, we do it routinely.
It's still, I think that, is there anyone from Medistim in the audience?
I think
There we
was-
are.
yeah.
Can you tell us what percentage of centers in the UK have a TTFM device? 30% own one. So we know that 70% are not using it. The 30% that own one may or may not be using it. So let's just say half of them are using it on their, let's just say half of the cases in those, then it's 15% penetration. That represents an opportunity. And I don't think that more than 15% of invasive coronary angiograms have routine FFR. In fact, I think it's much less than 15%.
Okay, I have a comment. You know, most of the photos that you showed about the flow measurements in the accus, the epicardial, you showed mainly the longitudinal aspects of the LAD. Don't you also see it at a 90-degree angle?
You can simply turn the probe at
Yeah.
90 degrees. It makes a prettier picture when you do it longitudinal.
Yeah. I mean, I must say that there are limitations to epicardial ultrasound. There is a learning curve
Absolutely.
involved. And yeah, I use it for every patient. I measure the flows, and then I use the epicardial ultrasound on every anastomosis. But I'm not using it to investigate the anastomosis. I'm using it to learn myself so that I can be confident when there is a problem. The other thing is, it's the epicardial ultrasound is easy to use on the Lima to LAD, but it's very difficult to use on the OM graft and the PDA. In fact, on the
Especially
OM
off
to
pump.
2, it's
off pump is bloody hard.
Very difficult,
And the
yes.
device is under development. It's you know, the company is working to improve its ergonomics and ease of use. I think we'll see a better device soon, but not very soon.
One more drawback with the current system is it shows you the diastolic fraction and it shows the systolic and diastolic components when you connect it to the ECG, but it does not record the blood pressure. You know, what a lovely thing it would be if the device came with such a manner that you would also have the blood pressure and the heart, blood pressure mainly, because that would give you some more information about the flow.
So Vipin raises a very important point, and that is that the measurements you get on flow and pulsatility index are pressure dependent. And I have a case that didn't show today of, you know, really unimpressive flow in a Lima to the LAD without a particularly high pulsatility index, decent PI, but a low flow, lower than one would expect from a good artery in a good quality vessel. And then I looked up and I noticed the blood pressure is 50. You know, the anesthesia resident was doing something foolish, and I asked them to stop that nonsense and get the pressure, mean arterial pressure. There's a systolic is 50. I now want the mean arterial pressure to be 80, and then we're going to retest the graft, and the graft was fine. So the conditions under which you measure the flow are important.
Yes, okay.
Thank you. Excellent presentation. I think it's a very useful tool, as you have mentioned, and there is a learning curve involved. if you're not doing it routinely and suddenly you have a problem in one of the cases and you want to check your graphs, that's where things go wrong. I mean, I was in Oxford before where every single patient used to get it. And every example you have shown, we have seen this. And one of the dreaded complications of cardiac surgery is putting lima on a vein, thinking it's a LAD. Oh. So one of our colleagues had a patient who he left the registrar to do, and the registrar said the flow is fantastic, 300-400 mLs flow. And then I'm sure David Taggart won't mind telling me this. And David Taggart came and said that, oh, there is a problem, I have to scrub. And actually it was on a vein graft. So, you know, it was put on a LAD afterwards.
It's put on a vein graft or put on
on a vein, thinking it's the LAD. So I think it's important. The other thing is, you know, the company says that you need to measure it closer to the distal anastomosis. So practically, how close do you go to the distal anastomosis?
Great question. So it is true, and it's actually kind of interesting to me. I think it reveals some of the limitations of the basic technology, that you will get different numbers, especially if you have a vein graft on the aorta with a high DPDT, rate of change of pulse pressure over time, at the anastomosis on the aorta, that will have a higher pulse stability index and weirdly a lower flow, but especially a higher PI if you measure it right at the anastomosis on the aorta. If you then slide that probe down to a couple centimeters above the distal, the pulse stability index may be half what it was measured at the aorta. It's the same graft, and the flow may be different too, but you know the flow is uniform. It's one pipe. It's one in, one out. The flow has to be equal at every point in that pipe. So no technology is perfect, and these aren't perfect technologies, but it beats wishful thinking.
Can I add something
or
to
self-congratulations?
Yeah. So I'll add something to that. So first of all, you have to measure the flows. Distally is better, but when you're measuring OM and PDA, especially if you've done off-pump and arterial, you can't go too distal. No. You might actually damage the grafts, number one. Number two, the flows, as John said, flow has to be same whether you measure it at the top or at the bottom. But if you measure it lower down, you're more likely to get information about the backflow. And sometimes that can be important.
I think it's important to measure it safely.
Yeah.
You know,
I think whether you do
as close to the heart as you can, as you can do safely and confidently, and doing it very proximally safely beats the heck out of tearing a graft distally, right?
I think whether you do off pump or on pump, it's the same concept, because you have to repeat the flows after you give protamine and after you have taken the cannulas out.
Yep.
So it lives with the same problem, and that's where the lima anastomosis check is important, because if you have the skeletonization too high up, you're not gonna get a great reading, isn't it? So it should be ideally around the middle or lower third of the lima, so that you can put the probe there, provided that you are taking a non-skeletonized mammary.
So I always take a skeletonized mammary and almost always have a radial artery coming off the side of the lita to go to the circumflex system. And I measure above and below that takeoff of the radial at the end of the case. And I just do basic arithmetic rather than struggling to get the probe down on the marginal. No. Another thing I would encourage you to do is, if you're doing skeletonized mammaries, they can get desiccated. They dry out a little bit during the course of a long operation. Be sure someone on your team is paying attention to that and keeping it moist. I usually have a syringe with papaver, lidocaine, heparinized blood, and plasmolite mixed up in a special cocktail, and it's the job of the second assistant to keep that mammary artery wet. Because if it's desiccated and spastic, you're going to have different measures at the end of the case than you did at the beginning. And then you're going to ask yourself, was it the protamine? Is there some problem? No, it's just that you'd let your mammary dry out.
The other thing I would add is, the company recommends that you do it at different times, but it's just a waste of time. And no. What I'm saying is, every time you make measurements, it is a time added to the operating schedule. You can't be measuring it once immediately after Lima to LAD is done, once before protamine, once after protamine. So we, in Edinburgh, we measure it only once, and if the values are good, that is fine. And I think, John, you have published in the Journal of Cardiothoracic Surgery, you looked at, from the request registry, you looked at all patients who had pre-protamine measurements and post-protamine measurements, and you found no difference, and you recommended that there's no need to measure them twice. And I think at the end of the day, you also have to be mindful of how much extra time this is going to add to your procedure. So measuring it once and getting good values, I think, is enough.
So when is the best time?
So either it can be just before giving protamine or just after giving protamine. For me, it is actually when the anastomosis are being completed, it is at that time I ask the nursing staff to bring in the machine. It takes them a few minutes to set up. When they are ready, I measure it.
But
if the protamine has been given by that time, I'll give it.
You've got to be pulsatile, right? I mean, you can't be arrested. And I don't think even having the patient on the heart-lung machine is a fair test. We want the patient to have weaned from cardiopulmonary bypass and be decannulated. Protamine doesn't have to all be in.
Yeah.
But I think you should be, the pulsatility index won't be meaningful unless there's a pulse.
So routinely in Edinburgh, we measure it after protamine. And that is one of the last things we do. Before
The only issue with doing it then is that window to redo has closed somewhat, and the hurdle that you have psychologically to reheparinize is not trivial. I think you're more likely to walk away, talk yourself into believing it's okay when it's not okay. So I do measure before. I measure after each graft because, again, we're using double mammary inflows. We're doing one, the next, and I measure each flow as I go. If they're all great, I don't measure them again. If there's an iffy one, then I'll measure it again after protamine and want to be sure everything's okay.
I mean, can I just add? I totally agree with what Dr. Puskas said. I think if you are, I mean, I do predominantly on-pump surgery. So if you're doing on-pump surgery, it's a quite big undertaking. You have taken the cannula out, you have come off bypass, and suddenly, surprise, surprise, your Lima or Rima graft is not great. So the way we used to do, I mean, in Oxford, the way we do the on-pump surgeons, when you have the cross clamp on, you construct the Rima or Lima graft, you have a look. If the flow is great, that's fantastic. And then you come off, and the vein or radial graft, you can just check it afterwards because then you're off bypass. Otherwise, you know, you sort of walk into a situation where you have taken everything out, you have reversed the heparin, and suddenly there's not great flow, and you're thinking, oh, you know, it's going to be all right, or the vessel is bad, you know, so I'm not going to redo it.
Yeah, so for on-pump cabbage, I would recommend that you do it after the venous cannula is out, after protamine is, protamine may or may not be given, but after the venous cannula is out and the heart is pumping, that is, measure it at that time. And if you want to intervene, all you have to do is put the venous cannula back in.
But what's the problem of doing it when you have the cross clamp on? There's no problem, because if
no
you
pulse.
but you can still
You can
see
measure
the
flow, from,
you can see
from
the
an
flow.
in situ mammary,
Yeah.
yes.
Because if there's technical problem, if you have done anything like purse string effect, or you have done something bad to the toe, you will see. I mean, I have had experience of 2 or 3 cases where the anastomosis I was supervising looked perfectly all right. We checked the flow, there was very low flow.
Yeah.
And then I redid the anastomosis myself, flow was completely different. Now, it's important to do it after cross clamp because you want to see whether there's any competitive flow or something like that. So I would strongly advise that if anyone is doing on-pump surgery, to check it whilst cross clamp is on, at least for the Lima and Rima pedicle grafts.
Okay, any other question? One, Piroz, yeah?
Sometimes when you're doing an off pump and you have a very small target and you check the flows right away, which I always do as well as you do, sometimes the coronary is still in spasm.
Yep.
And
It improves.
It improves.
You do another graph and come back to it, and it's doubled.
Correct. But it's only painful when that is a sequential anastomosis.
Yes. I have felt that pain.
So, yeah. That's
Okay.
It's
Any
a painful
other comments?
business.
Yep. Okay, what I would recommend is, I mean, many of you will have the machine in your hospitals. Just use them and get onto the learning curve. It's a great tool. Okay, with that, we'll have the last talk of the session. Daniel is going to represent Gianni Angelini from Bristol, and you're going to talk on the vein grafts.
Yes, so of course,
Daniel Fudulu.
you noticed I'm not Professor Angelini. I'm a clinical lecturer in Bristol. I've been working with Professor Angelini for a long time. These slides have been prepared mainly by Professor Angelini, so I'll try to convey our perspective on vein grafts in contemporary coronary practice. These are some nice slides that show, first of all, acute vein thrombosis, lower down plaque rupture in black with thrombosis, and to the right, we can see intimal hyperplasia with lumen narrowing and complete occlusion of the lumen. Undoubtedly, there is a rationale for arterial grafts as discussed by the previous speakers. Veins do have a problem of vein graft failure, and this is a complex molecular process of thrombosis involved in early graft failure, intimal hyperplasia later on, and atherosclerotic plaque rupture later on. And this has been clearly described that vein graft failure occurs early in 10 to 15% in the first 30 days, mid in 20 to 30% of cases due to neointimal formation, and later on there is macrophage infiltration and atheroma rupture. This is a nice coronary angiogram picture that shows intimal hyperplasia in the mid portion. And we know for a long time that the graft failure rate it's around 50 to 60% after a decade. This is the literature that we know. However, despite these very poor results, as already alluded by the previous speakers, we still use Cephalus vein graft as the most common second conduit in CABG after Lima. And there are around 1 million procedures performed worldwide, procedure CABGs performed worldwide annually. And still, 80 to 85% of the grafts are vein grafts. And actually in the USA, the percentage of multi-arterial grafting is quite low, less than 10%. In Europe, is believed to be higher, 10 to 15%. And there has been tremendous funding into trying to improve vein graft patency with either external venous support, gene therapy, mRNA therapies, and mainly surgical techniques such as harvesting the vein as a pedicle with the surrounding fat, controlling the distension pressure as shown by the Bristol group, and the preservation solutions such as using buffer solutions. This is a photo of one of Professor Angelini grafts, and he told me that this was in his early days, and he was very keen, and we can see a sequential Lima graft to several territories. And most of us like to believe that we're all multi-arterial surgeons. However, in this study that we performed on the NAXA, this is a study by Jeremy Chen, who's, I see him in the audience. He's one of our academic clinical fellows. It shows that actually from a quite higher rate of multi-arterial grafting in the 2000, this has slowly decreased up to 2018 to around 10%, similar to the American data. And previous speakers already discussed that this underutilization is multifactorial. It's clearly more technically demanding and increases overall time, particularly at the beginning. In UK, we did have risk-adjusted mortality, which was again a deterrent. And the European guidelines clearly state the use of a second arterial grafts as a 2A indications, and even the societies admit that there are limitations, as most of the studies, mainly comparing BIMA with single LIMA, are observational. And possibly the high crossover from BIMA to LIMA noticed in the ART trial showed the reluctance of surgeons to use BIMA in the clinical practice. However, we have to admit that saphenous vein graft patencies have improved quite a lot since the 19th and 1990s. And certainly there has been a tremendous advance in surgical techniques. I was talking with Professor Angelini the other day, and he was saying that during his training they never used to use loops and techniques were more primitive. So certainly techniques have improved quite a lot, and some studies now quote rates of as high as 80 to 90%. The evidence from my point of view remains conflicting, and it's sometimes very difficult to make sense of this, specifically when we look at clinical trials, the populations that we include in these trials, the performance bias, and of course the operative experience of the surgeons. How have we assessed patency? Have we used coronary angiogram? Have we used CT angio? And most importantly, to what extent graft patency translates impacts on clinical outcomes? Because as Professor Pashkas already mentioned, there can be silent, graft occlusion, and patients can live even with blocked grafts after an operation. This is an early study published by the Bristol group in Lancet that was looking at on-pump and off-pump, and that showed no difference. But what I want to draw your attention is that in the Bristol data, we've seen that the saphenous vein graft patency was quite high. This is a South Korean group, Kim, that they showed that actually Y vein graft can do as well as a Rita graft, because of course it benefits from the eluting effects of the Lita graft, the inflow. And again, this has been shown in longer term follow-up, very good results. The Cascade trial again showed quite high patency saphenous vein graft at 7.6 years. And as one of the members of the audience noticed, this post-hoc trial analysis of the COMPASS trial had showed that saphenous vein graft, contemporary outcomes of saphenous vein grafts are not too bad actually. The failure rate was 10.4%. There's more interesting data and probably more conflicting. We know the VA trial by Goldman, at 1 year there was no difference in patency between saphenous vein and radial, and they've also done a very long-term follow-up at 17 years when there was no actually difference in survival between saphenous vein graft and radial. And more controversially, this hasn't been published yet to my knowledge, but the REPCO trial showed the opposite, that on long-term follow-up, up to 15 years, actually, a radial artery is protective and reduces MACE significantly. So again, quite conflicting evidence. But if we have to use the vein, we have to do our best to improve its patency. So obviously, we need to select the target for anastomosis, free of disease. Again, the size of the vessel matters a lot. We've already discussed about the importance of FFR and functionally significant lesions. No touch technique for graft harvesting. and use of intraoperative graft flow measurements, like after mitral valve surgery, we use TOE to assess our results. I see no reason why we shouldn't use this routinely after heart operations, after CABG. But undoubtedly, the wide use of dual antiplatelets in our patients have made a tremendous impact on these quite good contemporary outcomes of saphenous vein grafts. And this comes mainly from the PCI cardiology trials. And again, the use of statin perioperatively, again, made quite an important contribution to improving vein graft patency. So we have to use common sense, but common sense is not so common. And actually, Professor Angelini has prepared here a case for us, and he's asking us, what would you offer to this patient and to this patient? Undoubtedly, this patient probably should receive a multi-arterial grafting. This patient probably might do quite well with a Lima and some vein grafts, if not even only vein grafts. But how do we achieve multi-arterial grafting? Undoubtedly, there needs to be a dedicated program similar to mitral valve repair, aortic surgery. We've already discussed about specialized training. We all consider CABG as the bread and butter of heart surgery, but there is a clear trend towards developing dedicated coronary teams that sit in the heart teams to make the best decisions for patients. And this is actually a nice article by Professor Poshkas on dedicated training in advanced coronary surgery. And that's it for me. Thank you very much.
Thank you, Daniel, for stepping in for Professor Angelini.
Thank you.
Any questions from the audience? Can I just say that as far as the saphenous vein is concerned, most of the, the patency figures that we have been quoting for 30, 40 years are actually from the 80s and the 90s.
Yeah.
And at that time, management of patients was very different. Nowadays, we have patients on statins, diabetes control is better, hypertension control is better. And therefore, there are many studies which are showing patency rates in the region of 80 to 90% as well. So that is just one comment on the contemporary, the use of saphenous veins.
I think that also emphasizes the importance of optimal medical therapy in postoperative surgical patients. There's no cardiologist who's going to put a stent in and not treat them with dual antiplatelet therapy and aggressive statin reduction. But we commonly put grafts in, send the patient home. They go to see their primary doctor and they say, oh, you've had coronary bypass. You don't have heart disease anymore. You don't need all these medicines.
Yeah.
And so commonly, we compare outcomes between PCI with optimal medical therapy versus CABG with nothing. And we still win.
Yeah.
Think how much better we'd look if we just did the right thing for our patients and insisted that they have the same optimal medical therapy that their PCI contemporaries have. Indeed, our patients have more complex and extensive coronary disease and probably other atherosclerotic disease elsewhere in their bodies and will benefit even more than the PCI patients from that optimal medical therapy that they're not getting.
Okay, so any other questions or comments? Yes. Can you wait for the mic, please?
Abdurrahman from Dublin. Any difference in patency of the graft as regard technique, endoscopic or open or skip?
I think this was the, I think this has been shown actually, there's no difference to my knowledge.
So many of the earlier studies showed that endoscopic vein grafts were not as good. However, with more experience and with better techniques, I think it's just the same now. You would agree, John?
I think it's very important to harvest every conduit with minimal or no trauma. And it doesn't matter which conduit we're talking about. No conduit is immune to being beaten up and then implanted on the heart. It doesn't matter. So if you're going to have endoscopic harvest, which we do every day, I haven't seen an open harvest in years and years and years. I would be out of business in New York City doing open vein harvest. That's not I can't do that. So we have 3 very dedicated people who harvest conduits, and that's all they do. Now, they don't do very many veins. They do endoscopic radial every day. And then I and the fellows harvest skeletonized double mammaries every day. But we are meticulous and uncompromising about the quality of the conduits. You cannot make a silk purse out of a sow's ear.
Thank you.
Okay, I think with this, we will bring this session to an end. Just one more comment. Yeah.
Excellent standing, Dan, and some fantastic presentations. Just one comment and thoughts to the rest of the chair as well, is that a lot of this seems to be related to training and making sure everybody's able to do the key steps. How do you think, and I'd invite everybody to comment, how do we think we ensure that the trainees currently today are developing those skills that they're able to qualify and provide this sort of a service?
Well, that's a very difficult question, but I think for surgeons who routinely practice off-pump surgery and who routinely practice arterial revascularization, they should be just a bit more open and train their residents. I think that this has to come from the surgeons themselves. The residents have to be a bit pushy, and that's the only way forward, I think. And I think centers which have a lot of good training, for example, Bristol, you've published results showing trainees, when they're trained, the results are just as good, and they go on to do off-pump surgery and arterial revascularization in other centers. You want to come in there?
Thank you. Yeah, I really would love to comment on that. I think we have to start from scratch, starting from our national training program where there's no marking on surgical skills. If you look at the new proforma, new matrix, those who are applying for ST1, you will see there's everything, like there's marks for audit, for research, for team play, for leadership. There's nothing for surgery, like how much experience you have. Second thing is, cardiac surgical program in EWTD era where the trainees are working 35 to 40 hours a week as opposed to Dr. Puskas' unit where they're doing probably 100, 120 hours, you know, how on earth do we reduce the number of years of training? I don't understand. So when I was doing training, we used to go to ST8 for the CCT. Now it's down to ST7. And I understand this has been imposed by GMC on the SSC. Perhaps these are the things the SSC needs to look at, because these are quite serious issues. Like, I work in one of the best training programs in the country. When we came out, we did around 600 cases. The next generation trainees are coming out with 350, 400 cases. The following generation, I think, will come up hardly with 200, 250 cases. And that's in one of the best training programs in the country, as shown in GMC survey. So I think we really need to start from scratch, and the society needs to be really aggressive about how they deal with these things.
You know, this gets to the whole issue of whether coronary surgery should be considered a subspecialty. You will not find a post in Britain to do arch repairs or even mitral repairs without some postgraduate training in that particular area. And I think the same should probably apply to coronary surgery. We founded it at Morningside, Mount Sinai Morningside Hospital, where I'm the chair, what I think is the first advanced coronary surgery fellowship in the world. We've now graduated 4 to a year for the last 2 years. We're in our next round. And these are people who have finished their training somewhere else, in Canada, Japan, Australia, America, and dedicated 1 or 2 years more training to master the skills of arterial grafting, and particularly no air to touch all arterial off-pump bypass. It is not a beginner's sport. The margin for error is minuscule. I mean, it's 1/10 of a millimeter. The margin for error in a mitral repair is 2 millimeters, 20-fold larger. And if the patient leaves the room with a little bit of MR, no one notices. If they leave the room with a closed LED, everybody notices. So it's a different ballgame.
Bala, you want to say something?
Yeah, well, I just wanted to add to what John has just said. I think one of the other things we shouldn't forget is everybody thinks coronary surgery is sort of a baseline on which you then build your experience as a trainee. Everybody thinks, oh, it's just a graft, it's a Grafts case, The trainers make it look simple. The trainees perceive it to be simple. And therefore, when they come to the end of their training, they have a reverence towards mitral valve repair. They have a respect towards learning valve sparing root or an archwork. They have no respect towards coronary surgery because they've mastered it in their mind. So when you go and tell them you need to relearn it, forget senior surgeons, trainees can't take it. They come to me through the rotation and they have to start from scratch from me. Otherwise, they don't do anything. So they have to relearn how to take memories. They have to relearn how to treat the heart when they do off pump. It's a whole relearning. So if the question is, how do I learn? The question is, be flexible in your mind. When you come to the stage that you want to learn it and you want to pursue an advanced fellowship in revascularization, start from scratch, because that's the only way to move forward.
Okay, I think we will summarize the session now. I'll quickly summarize everything. A message for everybody: use TTFM in all your patients. FFR in cabbage. Do not undergraft. Do not believe in the FFR all the time. But if the FFR is higher than expected, select vein grafts rather than arterial grafts. And a message for everybody: try to increase your experience in off-pump surgery and arterial revascularization surgery, because that may benefit some of your patients sometime. And I think there are drinks and canopies available in the exhibition hall, so let's all go there. And a big thank you to all the speakers.